We are now about to hear more about from our next speaker, which is Nils Erik Gilhus, who is a professor in neurology at the University of Bergen. I would like you to give him a very warm welcome as our next speaker today, where he is going to give us the lecture, The Need for International MG Guidelines in Diagnosis and Care. Welcome, Nils.
Thank you very much both for the initiative of organizing this meeting and for inviting me. And thank you for a very inspiring first introduction by you, Alma. I really liked it. I started with this slide, as this was my first slide in a meeting 2 years ago in Denmark, a Nordic meeting initiated by the Danish patient organization. They decided the title that they urged me to talk about the need for international MG guidelines in diagnosis and care. These are just to show that I have received support from several companies in Myasthenia Gravis, active in Myasthenia Gravis. And this is good for all of us because it shows that there's new treatments underway and new possibilities, which was not so for many years for Myasthenia Gravis. This was also a slide that I concluded with in the Danish or the Nordic meeting in Denmark, that there are experts in all Nordic countries on Myasthenia Gravis. In the Nordic countries, we have similar treatment traditions and health systems. I felt very much at home with your presentation of how we do it in Iceland. And I think it's similar in the other Nordic countries, and also the ambitions should be similar. We have a tradition of user involvement. And at the time, I listed this Nordic or Scandinavian journal as a possibility for publication such guideline. We discussed a little bit what could be done. Should it be a guideline? Should it be a systematic review? Should it be ordinary review? Or what we ended up in more like a guidance article. Guideline, you called it a guideline. And guideline, formally, it's very strictly regulated what you can write in a guideline. Everything should be proven in scientific studies. We thought it might be better and more interesting to call it guidance, because then our opinion as a group could show more clearly in the end result. Because not everything is really proven in controlled trials in Myasthenia Gravis. Not all treatments have been tested versus placebo treatment, for example, and there are very few studies, formal studies, comparing different treatments in Myasthenia Gravis. And then another reason for working on this was the new treatments that are underway, high costs related to such treatments, and also a discussion about is it possible or how should we refund these new treatments. The talk in Copenhagen, it ended up with a lot of questions and discussion, and I must say enthusiasm, not least from the patients, from the users, not least from Iceland. So I was stimulated to continue to do this, and a few weeks after the meeting, I asked the Danish Association if we should try to continue to do some work on this, and if this association would be interested in being some sort of secretariat for the work. And I got the response back after some time, but they needed to, of course, to discuss it. And it was a very positive response back. And this ended up with we making a consortium of the people that had attended, or key people that had attended the meeting in Copenhagen, and not in Copenhagen, in Denmark, and we managed to come up in a surprisingly short time for a scientific paper, because everyone did as they had promised. So we ended up with this meeting. We had this meeting in nearly 1 year after the first meeting, where we went through the various aspects of this guidance article, which was then published some months afterwards, and we ended up to be more ambitious than we were originally, as it was published in a European journal, so a true international journal, and not only in this Nordic journal. And this sums up the main results. It's a very nice figure made by Cindy that made this draft, and you see there are key people in all Nordic countries as authors. And several of these aspects will be covered by talks later today, and I will also talk of some aspects, but not everything, of course, in this paper. What I think is interesting is that on this slide we've written a Nordic guidance for treatment. But when we sent it to European Journal of Neurology, they had some comments, and one comment was that they wanted us to remove Nordic guidance. So it should be a general guidance, and we did that. So we thought that it was that we should, so that this come from north of Europe, but they say that no, this should be equally important for everyone. So that was one aspect. Another feedback we got before publication was that the reviewers, they said that couldn't you write about everything in myasthenia, not only those with had generalized disease and not only those with acetylcholine receptor antibodies. So that was also for us good. They wanted more, but we said no, we can't do that. We are only allowed to write 6,000 words, and we have to concentrate on this most dominating group within myasthenia gravis. I'll now say something more general about myasthenia, and I like to start with this slide, which is a specialist slide, but it shows the key pathogenic factor, the key disease-inducing factor in myasthenia gravis, that there is a reduced function of the acetylcholine receptors in the muscle membrane. Acetylcholine is delivered as normal, but there are too many inactive receptors to produce full muscle strength. So these antibodies, through several mechanisms, they induce a reduced function or reduced number of these receptors, and that leads to reduced muscle. And a few patients have antibodies against other molecules in the muscle membrane, but this again impairs acetylcholine receptor. So also in these patients is a dysfunction of the acetylcholine receptor. This rather, in a way, simple pathogenesis disease mechanism should lead to muscle weakness. But when we discuss with patients, they come up with many aspects, most of them linked to this reduced muscle function, but also other aspects, and I'm sure many of you are aware of this, such as fatigue, reduction of daily functions, pain, depression, speech problems, which of course can be directed directly to the muscle weakness, and these worries about drug side effects and safety and treatment availability. There are many aspects of the disease. When it comes to myasthenia gravis and to trying to optimize treatment, we tend to try to subgroup patients. We all know that patients differ in symptoms, they differ in many aspects, severity. And our response is trying to find biomarkers or other aspects that can subdivide patients in a good way. And one clear subdivision is according to antibodies. So, and there are, as illustrated on this, some differences in where they have most symptoms in the various subgroups, those with acetylcholine receptor antibodies, those with MuSK antibodies, those with LRP4 antibodies, and those without detectable antibodies, and also added here those with LEMS, Lambert-Eaton myasthenic syndrome, which is another disease, but with very similar symptoms to myasthenia. The most important for diagnosis is a history of the patient, what the symptoms, what the patients tell, and what is typical is, as you know, cause fluctuations and also this possibility of improvement and reversibility of symptoms. Just put this in, there are similar diagnoses which are important to recognize as a doctor, and congenital myasthenic syndromes is one aspect of this. These are rare disorders, but in some patients there are genetic changes in the acetylcholine receptor or in other molecules that co-act with acetylcholine receptor, and they have similar symptoms, but there is not an immunological background of these disorders. This is a further subgrouping of patients with myasthenia gravis, and it's generally accepted, and you see that it's related to antibody, but also to age at onset and to thymus pathology, and we come up with these different subgroups. And this is a way of trying to adapt the more general treatment algorithms or guidance or guidelines to personalized therapy. There are discussions, and I'm sure that in the future there will be further subgrouping. There is one aspect, is, for example, children with myasthenia gravis. They may be a separate subgroup, and there have also been arguments that those with start of their disease in high age, in, for example, above 65 years, that they should be a separate subgroup with very late onset. Then it's a question of diagnosis, and you know that detection of antibodies is a key thing for a diagnosis, because these antibodies are so specific. If you have symptoms and antibodies, you have the disease. But now, you also saw that there is a quite large group, 15%, perhaps 20%, that do not have antibodies by standard tests. And now we're trying to make better tests, cell-based assays. They are recently also commercialized, so you can buy this as kits, these cell-based assays. And it's still a challenge to make highly sensitive, but still specific tests. It's very important that they are specific, that you can rely on a positive test result. This is a very complicated, and it's not to read everything, but it's just to show how the discussions are ongoing. This is a European initiative, how to define the group without antibodies. It is a challenge because antibodies are such a good positive marker, and neurophysiological tests are most important to diagnose this without antibodies. Repetitive nerve stimulation and single fiber EMG are the two tests, highly specialized neurophysiological tests. And again, it's a question about, should be sure that they are both sensitive and specific. Especially specific is important, that you not end up with a diagnosis of myasthenia gravis without having it been treated for years, perhaps with no response, with a wrong diagnosis. Then some words about outcome, and traditionally we say that patients with myasthenia gravis do well. This was data from Duke University. One of our PhD candidates some years ago looked into their material, and you see that most patients do well with in remission with only ocular symptoms or with only mild symptoms. But there is 10–15%, perhaps up to 20% of patients in some centers that continue to have moderate symptoms and could be regarded as difficult to treat. However, also in those with mild symptoms, there are worries, and many of them say that they should be better, that it's not really a fully satisfactory condition. We have this data regarding death, and Alma, you showed some interesting data from Iceland. This is recent data from Denmark using the Danish, not only Denmark, it's Denmark, Finland, and Sweden, that looked into deaths from their registries, and they compared the mortality with a control population. And you see that there in all these three countries it was a significant, slightly higher death rate in those with myasthenia. It's not unexpected. It's not worrying for each individual, but it should be recognized by the health system and reflecting that it is a severe disease and should be treated well. And if not treated well, there is still an increased death rate that has changed much from 2000 to 2020. There is a previous publication some years before this, and then it was slightly higher. That was only in Denmark. And you see it's slightly higher in females in this, study. Then it's a question of quality of life, and the people in Oslo, led by Marion Bolding, did a test or examined the quality of life in patients with myasthenia gravis, and this is reduced as expected, especially on items linked to muscle strength and activities where muscles are needed, and it is reversible in in most items. It's reversible when the disease is improved and the patients are in remission. So also in those with mild symptoms, of course it influences well-being of the patients. For example, worries about future, worries about side effects of treatments, things like that. We did a recent study about costs of myasthenia gravis, and we were using the Norwegian health registries. It was also we looked also then into how many patients in Norway and the prevalence and the incidence of the disease, but the main aim was to define costs, which again is important for you, and of course this is also an argument for improved treatment, that there are costs related to the disease, and as you see there are several items, direct costs, expenses of drugs, of hospitalization, but also secondary cost, productivity loss, because some patients are not working because of their myasthenia, and this more, which can be estimated. Of course, it's not as precise, it's not hands-on the cost in a way, but there are ways of estimating value of lost life years and quality of life, which is 1/2 of the cost, and you see these costs are estimated in euros. This is the number of episodes with the diagnosis of myasthenia gravis in the Norwegian patient registry during the last years, and you see that the number of consultations for myasthenia gravis is steadily increasing during these years. The number of patients is stable. It's not an increased number of patients. So this illustrates that both patients and doctors say that we need to do better. They want more consultations, and it's an agreement in a way upon this, that there are more and more consultations. I think the reason why it's not increasing during the last years on this slide is the COVID-19 epidemic that, of course, influenced consultations in hospital for non-COVID cases. This is just to remind that it is a reversible disease in the neuromuscular junction where the attack of the antibodies are on the acetylcholine receptors. There are healing processes, there are stem cells, there are production of new acetylcholine receptors. So if you can suppress the destruction of the receptors, new ones will be, new and healthy ones will be produced, and they will survive in a good way if you can suppress the attack of the antibodies and the complement and all these factors. So when discussing treatment, it's of course mostly a discussion about effect, but also safety, which is equally important. It's a cost-benefit question, and it's actual use, what patients really use when they, or even if we decide this or that. There are several new treatments, some established and some not yet approved. And these are acting on the B cells, on the plasma cells, and also these FcRn inhibitors and complement blockers. And these two drug classes are especially much discussed. They are effective. I'll show some slides that they are effective. They seem to be very safe. There are thousands of patients using these drugs in Germany, in Italy, in the United States, but no one in the Nordic countries, because they are not approved because of very high costs. There are ongoing discussions and negotiations between the companies and the health authorities, perhaps also in Iceland, and they are not yet approved because of their high costs. These B cells are interesting in a therapeutic perspective because they are the ones that are producing the acetylcholine receptor antibodies and the antibodies, and there is ongoing research finding better treatments that block these B cells for production. Rituximab is a drug used today. It's not terribly effective in myasthenia, but in some patients it works very well. This acts on these B cells. There are ongoing research finding better anti-B cell drugs. The complement inhibitors are important. They inhibit a complement, which is part of the inflammatory system of the body. And there are several drugs, and this was the first one. And you see that the ones that received the drug did much better than those that received placebo. And this effect, it came on during the first few weeks, 1 to 2 weeks of the treatment, and it remains over months and years. The other new treatment that is FcRn blockers. What they do is that they reduce the IgG, all antibodies in the body, all IgG antibodies, including the acetylcholine receptor. So this is the other group, which has been shown to be very effective, as shown in this slide. It's, for some of you, it's probably too specialized, but it is a fast-acting effect during the first few weeks, and it remains as long as they receive the drug. And when the drug is out of the body, of course, the situation goes back. And you see again over here the comparison between the numbers improving with placebo and with active drug. I think I'll skip that. So this is I would say, the present treatment algorithms that we will discuss more in the later talks. This was something we published some years ago in a European initiative in 2019, and I've added this, as I believe this is my personal adding to this what we agreed as new developments. We have, at least in the Nordic countries, say that rituximab is an alternative first-line drug. We had it down here initially, but in the Nordic, we agreed in our Nordic guideline that rituximab is an alternative early treatment. And these new drugs, complement inhibitors, FcRn blockers, they definitely add value. They give new possibilities in myasthenia gravis treatment. From a medical point of view, from a neurological point of view, they should absolutely be available also for Nordic patients, because they add value to a group of patients with severe disease. And also we had something about in the acute situation, intensive care, special interest for some of the audience, that, and also here these new drugs have a possibility to use because they act during the first 1 or 2 weeks. So this is what we ended up with, this slide, which we will hear more about later. And then my last slide is that we are now talking about the Nordic initiative. We are in Iceland, but of course it's a global perspective, myasthenia gravis. There are differences between countries, poor countries, rich countries, but also differences within countries. So thank you for your attention.
Thank you so much, Nils. We now have the great honor of posing questions to Nils. So if there's anyone in the room who would like to field him a question, then we will hand you a microphone. Are there any takers?
Then I will start. As an MG patient, and we talked about this, we want to ask you, do you think MG is underdiagnosed or misdiagnosed as, for example, ME, fibromyalgia, or similar diseases? Do you think that is happening a lot?
I think there is definitely a diagnostic delay. Many patients with myasthenia will say that they had symptoms for quite a long time before they were diagnosed, and many will say that they went to their primary care doctor or even their neurologist before they had it diagnosed, or they even diagnosed themselves. However, I do not think that in the society there are a lot of patients with myasthenia undiagnosed. We have seen that the number of tests for acetylcholine receptor antibodies in Bergen has increased very much during the last years, and the last 10 years, 20 years, 30 years, increasing number of tests, but there are not a very much increasing number of patients. So that indicates for me there are not a lot of patients. If you first think about it, you diagnose it. And I think it's important also to stress that there are many patients, as you know, many individuals with fatigue, unspecific fatigue. I'm so tired. Could it be myasthenia? It's not. They should have this muscle weakness, diplopia, or not just that they do not manage to work or to do their daily tasks. That's not myasthenia.
Are there any other questions from the room for Nils? Yes?
I'm of course also happy to answer questions in the break afterwards. I'll be here during the day, so if some of you have something you want to ask, so I'm happy to answer that.
Hello, Nils. Is it on? Do you hear me? Yeah. Okay. Are people? I know this one guy with the eyes like I saw on the up on there. And are you able to be born with this, or is it something that you gain over age in some way? Yeah, that's it.
You mean how it develops during the years? Or?
I know this guy that has eyes like this that I saw up on the counter before.
Yeah.
And he's always getting worse.
Oh yeah, there is the symptoms between patients differ very much. Most patients have some eye symptoms, either that they have diplopia, that they see two pictures, or that they have this drooping eyelid, but not everyone. And even if you've had a drooping eyelid for a long time, it is reversible. We see some patients that have had it for a long time, and then they get new and better treatment, and then it improves. So I would say that everything is reversible, but it can also worsen. So if you don't have had eye symptoms for more than 2 years, you will probably not have them later on.
Hi, my name is Erika. I'm an occupational therapist. And I'm wondering, you talk about treatment, medical treatment, but is there anything environmental that the person can do to get better?
We'll discuss many aspects of the disease in later talks. Alma mentioned physical activity, that will be a topic. Things like diet and things like that is what you think about. A healthy living condition is always good, especially good if you have a chronic disease as myasthenia gravis. It's nothing clear in the environment that causes myasthenia gravis. We do not know why people get myasthenia gravis in the environment. So as also Alma said, we do not know any real prevention of the disease. But generally, healthy lifestyle is good, and especially good for patients with myasthenia.
Thank you so very much, Nils, and thank you everyone who fielded a question. Can we give him a warm round of applause?